I'd like to welcome you here to this seminar. Thank you so much for joining us, whether you're joining us live or you're viewing this later as a recording. We are so happy to have you with us. My name is Naomi Hoffer. I'm the program manager for the Sheri Sobrato Brisson Brain Cancer Survivorship Program. And with us also in the background here as part of our program is Alexa Greenstein, who is our survivorship nurse practitioner, and Mary Destree, who is our Marin Expansion Program Liaison, who's expanding our supportive care services for survivors and caregivers to our Marin patient and caregiver community. This webinar is part of our regular Living Well After Brain Cancer Treatment webinar series, which is part of our growing survivorship program, thanks to a generous donation from Sheri Sobrato Brisson. I know many of you, many survivors are interested in medicinal cannabis and have heard a lot about it, but there's a lot of questions. So what do we know and what don't we know? We're going to talk about that today with our experts. So first of all, we're going to be talking a little bit about the history and overview. What is cannabis and what are the components? What are the therapeutic uses? What do we know that it's used for and what it might be beneficial for? We're also going to hear about the research and current findings that we know exist right now. What do we know about this? And then turn around what this means for you as you're considering using this for your own therapeutic uses. So after we hear from our panelists, we're going to have some time at the end for Q&A, and we invite you to submit your questions using the Q&A box. And then we're going to have an after the show segment where we will hear from survivors and hear how those who are using it for brain tumor recovery and management of side effects, how it's going for them, and we'll have a chance to hear from you as well and hear your questions. So I feel very privileged and honored to introduce two speakers with us today who are very well versed in this subject matter. Dr. Donald Abrams is the immediate past chief of the Hematology Oncology Division at San Francisco General Hospital and professor of clinical medicine at UCSF. He has an integrative oncology consultation practice at the UCSF Center for Integrative Medicine, the Osher Center for Integrative Medicine, and we are pleased to have him also as part of our regular survivorship programming at the UCSF Brain Tumor Center. Alongside his expertise in cancer nutrition and botanicals, Dr. Abrams has a long history of interest and involvement in clinical research that evaluates medicinal marijuana on various patient populations. He co-authored the chapter on cannabinoids and cancer in the Oxford University Press Integrative Oncology text that he co-edited with Dr. Andrew Weil. He co-edits the National Cancer Institute's Cannabinoids and Cancer website, and he was also a member of the National Academies of Sciences Committee that published the Health Effects of Cannabis and Cannabinoids, Current State of Evidence and Recommendations for Research, published in January 2017. We're really honored to have him with us today. And we also have Dr. Eduardo Rodriguez. Dr. Rodriguez is a glioblastoma or GBM clinical trial data scientist in the Brain Tumor Center at UCSF. He is a trained physician who graduated from National Polytechnic Institute in Mexico City and also holds a master's degree in clinical research from UCSF. Dr. Rodriguez currently serves as co-principal investigator in the study on the impact of cannabis on the quality of life in patients with central nervous system tumors. We are truly grateful to have him here as well to share his latest research with us. We'll first hear from Dr. Abrams, and then from Dr. Rodriguez, and then back again to Dr. Abrams. But Dr. Abrams, thank you so much for being here, and I will now turn it over to you.
Thank you, Naomi. It's a pleasure to be here. So, as mentioned, I am going to start out by giving you a little bit of background on what cannabis is, what cannabis isn't, what we know about it, and how long we've known what we've known. Okay. So, yes, so this is my topic. What do we really know? Want to start out by reviewing a little bit the history of cannabis and what it may be useful for. So this is the so-called Siberian ice princess. It's a mummy that was very well preserved in the ice in Siberia. She was so well preserved that her tattoos are actually being copied, I understand, by some millennials. But in any event, she turns out to be, under an MRI scan, a woman in her mid-20s who appears to have breast cancer that spread to her bones. And around her waist was a belt that had a pouch at the end of it, and in the pouch were the flowers of the female plant of Cannabis sativa, suggesting that this woman, dated about 2,700 years ago, knew about the potential medicinal benefits of cannabis. It's postulated by the anthropologists or archaeologists or whoever makes these hypotheses that perhaps she was using cannabis to treat the symptoms of her cancer, if not perhaps even the cancer itself. And again, I think that's a bit of a leap because we don't know that everybody in this tribe wasn't buried with cannabis around their waist. So cannabis has been a medicine probably for the last 3,000 years. It's one of the oldest known psychoactive plants, Cannabis sativa or Cannabis indica. Its reported first use, again, was 3,000 years ago in China, south of Mongolia, made its way along the Silk Route to the Indian subcontinent, and then further west into the Arab world, where it was widely used as a medicine. Cannabis was brought to the West by W.B. O'Shaughnessy, who was a British East Indies surgeon who was working in India and saw all the potential benefits of cannabis and brought it to the United Kingdom. At that time, it had many uses, supposedly, as a pain reliever, relaxing agent, anti-inflammatory, against muscle spasms, and also for seizures. At the beginning of the last century in the United States, most of the forerunners of what we recognize today as big pharma had cannabis products available for physicians to prescribe to their patients. Cannabis actually fell out of favor in 1937 with the introduction of the Marijuana Tax Act, where the Mexican word for the drug was used to sort of fool physicians. The act was introduced by a prohibitionist who felt that widespread use of cannabis by African-American jazz musicians and Mexican migrant workers was going to lead to increased crime and mental illness in the United States. So ultimately, cannabis was removed from the United States formulary. We know that cannabis is potent because of chemicals called cannabinoids, which are present in the plant. We believe that there are at least 400 different chemical compounds, and of those, about 140 are these structures that resemble delta-9 tetrahydrocannabinol, which is actually the main psychoactive agent in the plant. Delta-8 tetrahydrocannabinol has been studied in Israeli children with cancer and felt to be an effective anti-nausea medicine for children getting chemotherapy. And then all of us are quite familiar now with cannabidiol or CBD, which again is a related compound to the delta-9 THC. Again, in addition to those three cannabinoids, there are at least 100 others, and there are other compounds in the plant itself that have medicinal benefit. So again, some of the non-tetrahydrocannabinol cannabinoids are CBD, which I'm going to talk more about, CBN, which is a breakdown product actually of delta-9 THC, and many people who use old cannabis, which is rich in CBN, say it's very useful for sleep. Cannabigerol, or CBG, is another non-psychoactive cannabinoid similar to CBD, which they say is going to be the next CBD. As yet, it has not been studied in clinical trials, but people are trying to grow plants that have more CBG than current strains do. I think a very interesting cannabinoid is tetrahydrocannabivirine, or THCV, which apparently decreases appetite for food, for alcohol, tobacco, and also for opiates. So this is, if we're going to go about developing individual cannabinoids as medical treatments, this one is one that we might hear more about in the future. And in addition to the cannabinoids, there are also flavonoids and terpenes, which give the different strains their characteristic smells. And it's felt that all of these work together in the plant to sort of balance the effects of the delta-9 THC, which again is the main psychoactive component. So it's sort of like the other compounds provide the yin and the yang, or the yin to the THC's yang, if you will. So they help increase and augment the beneficial effects of THC and perhaps decrease some of the adverse effects. So since cannabis was removed from our formulary, we haven't learned a lot about what it does therapeutically, because it's very difficult to study since it's a Schedule I compound, which means that it has a high potential for abuse and no accepted medical use according to our federal government. But over the past 70 years, since cannabis has been prohibited, we've learned a lot about how it works. Basically, all of us have two different types of receptors for those cannabinoids. The CB1 receptor is one of the most densely populated receptors in the human brain. Unfortunately, we don't learn about that in medical school. That shows you the extent of reefer madness. The CB1 receptor is distributed widely throughout the whole body, and this receptor is found in all animal species down through sea squirts. The CB2 receptor was originally not felt to be in the brain, but subsequently has been identified, but not at the great density of the CB1 receptor. The CB2 receptor was initially found in cells of the immune system, in the spleen, and in the peripheral blood in the natural killer cells and the B lymphocytes, suggesting that this receptor has something to do with immunity. So why do we in all animal species down through sea squirts have cannabinoid receptors? You've never seen a monkey smoking a joint. Well, similar to our own endorphins, our own endogenous opiates that we also make endocannabinoids. We make our own cannabinoids, chemicals similar to THC and the other cannabinoid compounds. The first was identified by my friend and colleague Raphael Mechoulam at Hebrew University in Jerusalem, felt to be the father of cannabinoid chemistry. And he named it anandamide after the Sanskrit word for bliss. Subsequently, another endocannabinoid, 2-arachidonyl glycerol, has also been identified. So why do we and all animal species have this system of cannabinoid receptors and our own endogenous cannabinoids? The endogenous cannabinoids are synthesized on demand, and when they complex with the CB1 receptor, they cause changes in the cells, particularly the CB1 in the brain cell, which lead to changes in our appetite, in control of immune function, muscles, and pain, in our thinking, in our nausea, etc. And when these endocannabinoids complex with the so-called CB2 receptor, they're also involved in alterations in our immune function, in cell proliferation, cells dividing, inflammation, and also pain. I think Michael Pollan says it best. Michael is a Berkeley journalist who wrote the book, The Botany of Desire. And he has a whole chapter on cannabis. And he says the reason that we and all animal species have these receptors and endocannabinoids is to help us to forget. And in his next book, The Omnivore's Dilemma, Michael is trying to gather his own food. And in each chapter, it's about gathering food. And in one chapter, he's sitting in the woods, holding a rifle on his shoulder, holding very still, actually crouched in the woods. And he said, this is painful. And out of the blue, he postulates that the reason that we and all animal species dependent on preying, P-R-E-Y, for our food, have this system is to help us to forget pain. So with that in mind, the activities of both THC and CBD, for example, do both share analgesic or pain relief as their main probably activity. THC, unlike CBD, is psychoactive. The CBD is felt not to be psychoactive, but it is antipsychotic for people who have those sorts of illnesses, and it also decreases anxiety. So I think it really depends on what we mean by psychoactive. It's obviously acting in the brain. It just doesn't get you high. And we live in a society, Puritan-derived, Judeo-Christian base, that thinks that being high is something that's not something we should strive for, and that's something that's a whole other discussion. So, you know, CBD has sort of catapulted to the top of the most favored cannabinoid list because it doesn't get you high, but I think it is psychoactive. And we know that, again, as Michael Pollan predicted, that in states where cannabis is licensed and available for patients, there has been a marked decrease in prescription of pain medications. Anxiety medications have also been released. It was mentioned that I was on the committee at the National Academies of Science, Engineering, and Medicine that reviewed 10,000 articles on the health effects of cannabis and cannabinoids. And these are some of the conclusions that we came up with as far as what it's most beneficial for. The largest body of evidence is really in patients receiving chemotherapy that cannabis and cannabinoids particularly are licensed and approved to decrease nausea and vomiting. We all appreciate that cannabis can increase appetite. And again, it seems to be very useful in patients who have chronic pain. Particularly, most of the clinical trials have looked at patients who have neuropathy or pain generated from damaged nerves. And cannabis in this situation seems to be much more effective than placebo and probably as effective as the currently prescribed gabapentin or Neurontin. I see many patients in my practice who really enjoy cannabis, sometimes just CBD, sometimes THC, sometimes both, as a treatment for their insomnia, saying that it definitely helps them to sleep. And then the question of whether depression and anxiety are relieved, I guess, can be answered a little bit by the graph on the right, showing that prescriptions for anxiety medications are markedly decreased in states where cannabis is available. Depression less so, but definitely decreased. So CBD, again, has gone from being an unknown cannabinoid to being the most favored. And I attribute that to my friend and colleague Sanjay Gupta, who did his first special weed in 2013. And in that show, he showed Charlotte Figge, a young girl recently deceased who had refractory childhood seizure disorder, go from a child that couldn't do anything because she was constantly seizing to the happy, smiling girl on the right, just after taking a drop of a CBD oil under her tongue. And this ultimately led to GW Pharmaceuticals developing the drug Epidiolex, which is now licensed and approved as a CBD treatment for children with this disorder. Prior to the large studies of Epidiolex, there were really very few clinical trials on the use of CBD in humans. Most of the information that we had to rely on came from test tube and animal studies. Very few clinical trials of CBD existed, but the in vitro and animal studies do suggest potential therapeutic applications. We actually did a survey of patients at 3 integrative medicine centers in San Francisco, Chicago, and San Diego, as well as clients in 10 dispensaries in those cities, asking people using CBD dominant products what they were using it for. And as you can see here, 50% reported pain as their main symptom that they used it for, but fully 63% or 2/3 were using CBD for pain relief. Again, 44% for anxiety, 1/3 for insomnia, and 20% for depression, and that's CBD dominant. We also asked how effective this was, and people rated it in all of these situations 8 out of 10 as far as being quite effective. Again, this is not a placebo-controlled trial, but this is the sort of information that we need to provide us with sort of avenues to determine what we should study next. Personally, however, I think CBD is a bit over the top. It's now a $23 billion industry. And at the farmers market at the Ferry Building, we were surprised to see a CBD sundae for sale that was sold out. And now there's CBD infused clothing that claims to prevent soreness before it starts. And then last week, or a few weeks ago, stressed zoo elephants are being given CBD oil to help them chill out and stop fighting. I'd love to know if that worked or not. So I am going to turn the session over now to my colleague who is going to talk about what we know about research in cannabis, in brain tumor patients particularly.
Great. Thank you so much, Dr. Abrams. We will hear again from Dr. Abrams and invite him back. And now I'm going to invite Dr. Rodriguez to come up and, as Dr. Abrams said, to talk more about the research being done currently with brain tumor patients at UCSF. Dr. Rodriguez, are you here?
Yes. Hello, Naomi.
Hi.
I cannot turn on my video. It's being disabled right now. Well, thank you very much for the invitation, and I would like to thank to all the participants for their interest in this talk. And I think thank you to Dr. Abrams for that good introduction on what's the overview of cannabis. So now what I would like to address is what is, Naomi, can you tell me if you're seeing my slides, please?
Yes, we see it.
Yes.
Perfect. I would like to address what is being done in the realm of specifically neuro-oncology with cannabis. As Dr. Abrams mentioned, the research really in humans is being poor, to say the least, because of many hurdles. And I think it's mainly because of all the legal aspects of it. So I'm going to reiterate a little bit of what Dr. Abrams already said. So the potential uses for cannabis is to treat nausea and vomiting induced by chemoradiation, to help increase the appetite and therefore the weight in our patients when they are undergoing chemoradiation. And cannabis moderately improved chronic pain. And the only cannabinoid likely to have a role in depression is CBD, although this is debatable because it's been done only in animal experiments. And as we probably know too, measure depression is a little bit tricky as well. And like Dr. Abrams mentioned, most of the patients that report using cannabis say that it improves their sleep quality. So medical cannabis as an anti-cancer, the first article that was released, let's say, was in 1974, which actually was on a press release by the Washington Post, where they claimed that marijuana psychoactive component THC slowed the growth of lung cancer, breast cancer, and virus-induced leukemia in laboratory mice and prolonged their lives by as much as 36%. I think this is unique in the sense that it was first published on a paper rather than in a scientific journal. And then afterwards, the scientific paper came out in 1975. And this is kind of like a screenshot of an enhanced image, of course. It's not the original image of both of those articles. However, it got the attention of the federal government, and it was when it got investigated, and then it was put under Schedule 1 by the DEA, which again, it poses many legal hurdles. Since then, there have been many efforts to try to prove that it's actually an anti-cancer agent. But again, most of the efforts have been done in animals and cells. And much of the research has been done in THC because of the mechanism of THC is well known, and CBD as well. And information on the beneficial effects of non-psychotropic cannabinoids is derived from in vitro and animal studies, like I already explained. And specifically to address the brain tumor realm is tricky because most of the studies or most of the drugs that are being developed to try to use as therapies prove to be effective in vitro or in animal models, in rats or mice or monkeys. But then when that is translated to humans, it doesn't always work. So that's definitely a place where we need to improve the research that we are doing on this realm in the brain tumor space. CBD has shown remarkable results in vitro. Like Dr. Abrams mentioned, this was first shown by the Israeli group, but the mechanism, unfortunately, for which it prevents tumor growth is not fully understood. There are many theories on why they do it. Some of them are, they say, because it depletes oxygen to the tumor cells, and that's a feasible mechanism, but is not proven yet. And there are very few clinical studies on cannabis and cannabidiol, like we already explained. However, all the in vitro and in vivo and animal studies suggest a potential therapeutic applications. So what's the evidence in humans that we have so far? Where I have a few examples here, and this was actually recently published on a systematic review that we did. So we did an exhaustive review of the literature, and we pulled some of the articles that we thought that were the most, not only the most interesting, but the ones that add to the literature in this topic. So in 2006 in Spain, this is also a friend of Dr. Abrams, Manuel Guzman, conducted a pilot clinical trial study of THC in patients with recurrent glioblastoma. And what he did was inject THC at different concentrations and different schedules in 9 patients. Unfortunately, what this showed was that it didn't help. So can you see my pointer, Naomi?
Yes, we can.
Perfect. So these arrows, this is just what I just want to go over this really quick. These are the MRIs of the patients. And this curve, what it shows is the growth of the tumor in centimeters, in cubic centimeters. And the arrows is when THC was administered. So as we can see, actually it didn't stop it. Same for here. And this was patients who needed a resection. So this drop that we see in the tumor is the resection. And then this is after resection. So it actually didn't help. However, it was a small sample and of 9 patients only. And some of the measurements and some of the how it was applied, it can be debatable. But it's a step in the right direction. In 2017 in England, Dr. Susan Short conducted a 2-part safety and exploratory efficacy study. And what we like about this study is that it was randomized. If people are not familiarized with this, is when people are assigned randomly to specific treatment or placebo in this case. So it was assigned to THC and CBD on a ratio 1:1. That means that it has equal parts THC and CBD, or to the placebo, which was nothing really. While they were undergoing dose-intense temozolomide treatment in patients with recurrent glioblastoma. So the first part, it was only 6 patients, and it was just to try to see if it was safe and it was well tolerated by patients, and they determined that it was. So they moved on to the second part, where 12 patients were assigned to CBD and 9 CBD and THC, and 9 patients were assigned to placebo. In this case, it was actually demonstrated that it was safe, and it showed good results for survival. In this case, it is one of the best studies, I think, The only issue is a small sample, and it cannot be generalized to everybody. As you can imagine, the results of 12 patients cannot be generalized to millions of people. So that's the caveat in this study. But it's a study, a step in the right direction, and I think that this is setting the basis for further research. And then on one of the Society for Neuro-Oncology meetings, Dr. Nicholas Blondin published this poster, the evolving role of complementary cannabis therapy in glioblastoma treatment. And he, at the University of Yale, he administered oil concentrate of at least 50 milligrams of cannabinoid per day for at least 1 month, plus standard of care treatments. This means radiation or chemotherapy. So, but it was just voluntary. It was not directed to specific patients, so it was to whoever wanted to participate in the study. So 23 patients were registered, and 15 of those 23 were using cannabis. So they observed good results compared to low use or no use of cannabis, meaning they improved their symptoms and they improved their tumor improved or got stable. But the issue, and I wanted to remark really these words, it was at least 50 milligrams and at least 1 month. This means that it was not the same concentration for everybody, and it was not the same time for everybody that they were using. So again, it's a step in the right direction, but it's not necessarily the best way. We cannot generalize with this type of results. And then in 2004, on the opposite side of the coin, let's say, as you probably know, there are other efforts that have been trying to show the hazards of consuming cannabis. And I like this paper as a good example on how some evidence can be misleading. So in this paper, what they did, it was a retrospective, which means they went back to the electronic medical records of patients over time of a large amount of people, but it was 130,000 patients from Kaiser who filled out a questionnaire from 1977 to 1985. What I think is interesting in here is that it was very close to that initial paper that was released in 1975. So maybe the people actually didn't answer sincerely because of fear of being stigmatized by either the government or their other members of society. But they were at least 25 years old, and patients were followed for 21 years. Retrospectively, they were not actually followed. They were not calling them in real time for 21 years. And he identified 20,000 to round up people who use cannabis at least once. The issue with this is that he categorized all these patients as cannabis users, and that's problematic because if you used only once, let's say that these are recent grads or even grad students level or in the age range, they could have been trying just for fun, and he categorized them as them using cannabis. He found that 9 patients who ever used cannabis at least once per month developed glioma. So again, this is problematic because out of the 130,000 patients that we started, he derived conclusions out of 9 patients. So we need to put in context, not only from the research point of view, but also in time, what's happening in society at that point, and what's the age of the group. So I will take these results with a grain of salt. And now, so after we pull all that information, Dr. Nicholas Witowski, who you may or may not know and see in the clinic, he's a neuro-oncologist and he's a director of clinical research in our department. He observed that a good proportion of his patients were using cannabis for some kind of issue, for sleeping, for anxiety, and they were saying that they were feeling better. However, in science and in medicine, we cannot just say because my neighbor told me that this works, I'm going to prescribe it. We need evidence. So we decided to do an observational study. Observational means we are not doing any interventions. We are not giving cannabis to anybody. We are just surveying. We're asking people how they use it. And this is because of the legal barriers, mainly the federal legal barriers. And we want to see how cannabis is actually impacting the quality of life of our patients over time. So we decided to use quality of life because that's our main goal, is to improve quality of lives of our patients. And we want to see if there's any differences between people who use cannabis in real time versus those who don't use cannabis in real time. So what we are doing is we are enrolling patients. We ask them a series of questions, and then every 3 months, we ask them the same questions. Slightly different, but essentially is the same idea, to try to see how they're feeling. For 1 year, I understand that this is not the best. The ideal will be to following them until they get better, or until they don't want to keep participating anymore. However, we have certain time constrictions. So we follow them for 1 year, and then we try to analyze what's happening with quality of life. So therefore, all patients can participate in this study. We have people who use cannabis and people who don't use cannabis. And both are equally helpful for our study, because we need to see if it's working, and we need to see, we need a comparator group. So this is what we have found so far. To date, we have enrolled 81 patients in our study. Out of 216, we are aiming for that number, 200 people. It's fairly balanced. We have 50 males and 31 females, and they have various degrees of using cannabis. I think it's interesting that the females that decide to participate are the most balanced, so it's almost 50-50 split, which is great for results and for us to be able to derive conclusions and then generalize those. And these are the main reasons why people are using cannabis in our clinic. This is not that they are being prescribed, it's mostly what's the symptom that or the reason why people think that is helping them. So we have the majority of people is actually using it to relieve any kind of symptoms, and I'm going to go over that shortly. Some people think that is helping them for the tumor treatment. Of course, we have the recreational users, which is totally fine. And then we have other symptoms. And in other symptoms, we include sleep aid and anxiety relief. We understand that this is a disease that can create anxiety in people, and this is definitely an important point to make. So these are the specific symptoms why people are using cannabis, which they're similar to what Dr. Abrams showed us before on the survey on CBD in the dispensaries. Slightly different. And we have here that the majority of our population is using it because they don't feel hungry because of anorexia, and they are trying to improve their appetite and their weight. For anxiety, for depression. In other, we said we are including here other symptoms that don't fit in any of these categories. For migraine and for sleep aid, and the rest of them are. I don't want to discard them just out of hand, but I think these are the more important ones. And interestingly enough, pain relief is actually not one of the main reasons why people use cannabis in our clinic. Again, this is self-reported. This is people are using cannabis because they think that it's helping them with this kind of symptoms. One of the interesting questions that is pushing forward this research study is that when we ask people before using cannabis how they felt, and this is on a scale from 1 to 6, and 6 is the worst that they have ever felt, and 1 is the best status, let's say, that they can feel. Before using cannabis, they report a score of 4, which is fairly high. And after using cannabis, it shrinks down to 50%, to 2, so almost normal. Again, this is self-report, and I know this is subject to some things that we call bias. And this is for recall bias, because we are just asking, if you remember how you felt before using cannabis, please let us know how you felt. So there may be some biases there, but I think this is still really interesting, and it's a good motivator for us to try to explore more of what's happening here. Again, this is self-reported. It's not actually what's happening. So now, to measure quality of life, we use a series of instruments, we call it, so surveys, really, that have been validated in large amounts of people. And we try to compare this, right? So the bars, when the bars overlay, that means that it's not statistically significant, but I think it's interesting to see how people who use cannabis actually feel more fatigue, more nausea, and more pain. This is interesting because we will expect the opposite. However, this is how people start when they initially go into our study. This is how they start. So now the interesting thing will be to see if 3 months from now this curve actually switch, and the people who don't use goes here, and the people the people that don't use goes up, and the people that use cannabis goes down. That will be an interesting flip to see. We don't have enough data yet to show you those data, but this is how is the baseline of our patients. And same for functional scales. This is actually the opposite. The higher the score it is, the better it is, and the lower the score it is, the worse it is. So physical functioning, role functioning, emotional functioning, and cognitive functioning. All these are actually statistically significant. And again, this is how people enter into our study. And what we aim in the following months or years is to evaluate this data on a time lapse basis. So the conclusion is, we think that this phenomenon also that we are seeing of how people using cannabis are actually doing worse is not because of cannabis that they are doing worse. Is because they feel they have more symptoms, and therefore they resort to cannabis. So we need to prove this over time, of course. And we think this because 58% of our patients have a high-grade glioma, which is an aggressive glioma. And they are subject to feel more symptoms, and this is why we think this is true. However, we need to complete enrollment to further evaluate cannabis over time and compared to non-users. So the general conclusions here is that more formal studies like this one, even if they are observational, are needed, but if they are controlled in a more controlled environment, like placebo, compared to placebo, or compared to different concentrations of cannabis, are needed to prove that it's actually working. It's also important to know that there are some interactions that we may or may not know because it hasn't been studied, and it can be interfering with treatments and other medications that patients might be taking. So we need to know more about this. And we definitely need involvement of community, physicians, scientists, lawmakers especially, and other stakeholders is needed. Of course, in community, patients are included because this is mainly driven for the benefit of our patients. And we remember that what is observed, if you come across with some paper or some press release that it claims that cannabis is helping for X or Y reason, if it's only being tested in test tubes or animals, that doesn't necessarily mean that it's going to work the same in humans. And this is why we need more research in humans. So having said that, this is an invitation for everybody to join the study. Again, we welcome both types of persons, people who use cannabis and people who don't use cannabis. They are equally important to our study to complete. If you have any questions, you can reach out to me, or you can reach out to the general clinical research coordinator line. And if you scan this QR code, if you have an iPhone or a newer Android, you can scan it and it will take you to this flyer and you can have that information. Thank you.
Thank you so much, Dr. Rodriguez. That's really great information, and I feel like we need to kind of put a pin in this and invite you back when we get more of your study results. So thank you. Mary has put in the chat box the contact information, so you have it. I apologize for the clicking sound. I don't know if that's going to resolve itself if it was Dr. Rodriguez's mic, but hopefully it'll resolve itself now. So now we're going to turn it back over to Dr. Abrams and really talk about what this might mean for you in some practical considerations.
Thank you, Naomi. Really appreciated Dr. Rodriguez's presentation. And I do want to note that many studies have found that same finding, that the people that are using cannabis at the beginning have more symptoms. And maybe that's why they turn to cannabis, because they're not getting relief from their conventional therapies. So what does all this mean? Let's put it together. First of all, often we're asked, what is the best way for me to consume cannabis? I see a lot of older women with cancer who go to the dispensary and they're told only eat a quarter of the cookie. These are people that feel that inhalation is bad and eating is good. So they eat a quarter of the cookie and nothing happens. So they eat another quarter and nothing happens. So they eat the whole cookie. And then they call me 3 days later after perhaps a visit to the emergency room with a not very good feeling, saying they're never going to do that again. So they're describing the pharmacokinetics, or what happens when we take THC by mouth. It takes a very long time to reach a peak plasma concentration, about 2.5 hours. And there's a delayed onset of activity, which is why people say nothing's happened, so they consume more by mouth. And then when you take the delta-9 THC, the main psychoactive ingredient, by mouth, when it goes through the liver on the so-called first pass metabolism, the liver breaks the delta-9 THC down into an even more psychoactive metabolite. So that's why people get more zonked, if you will, when they eat edible products. On the other hand, if you inhale cannabis, either via smoking or vaporizing, not vaping. I hate vaping. That's the wrong word. I'm sorry, vaporizing. Then the effect is much more rapid. The peak plasma concentration occurs in 2.5 minutes and very rapidly declines over the next 30 minutes. And since less of it goes through the liver than when you take it by mouth, you create less of that 11-hydroxy, more psychoactive metabolite. So I tell patients, if they would want better control over the onset, the depth, and the duration of the effect, that inhalation is probably better than oral ingestion. And when I say inhalation, I mean vaporizing, which means vaporizing the plant. As an oncologist, I've been quite concerned about this trend towards vaporizing an oil, because I definitely know the long-term health effects of inhaling a vaporized or combusted plant, but not an oil. And I think that panned out to be a concern. So I'm all in favor of vaporizing plant, or even smoking in a bong, or even cigarettes, because I don't think the danger is very large. We now have tinctures and oils, and in fact, even chewing gums. And when you put these in your mouth, you immediately absorb some from under the tongue. And then, except for the chewing gum, you swallow the oil or the tincture. So you get the sort of benefit of both inhalation and oral ingestion. And I think more and more people are turning to these oils and tinctures. People also, in my practice, have claimed that suppositories work. Mahmoud El-Souleh, who grows all the cannabis for the government research, said that he doesn't think THC could be absorbed rectally, but many of my patients make their own suppositories out of olive oil or coconut oil, I forget, and they say it definitely works. And then there are topical products that patients often can use and get at a dispensary and find them very useful for local pain in arthritic joints or muscle pain. So there are many, many different options for cannabis now. Again, as an oncologist, I am quite anti-sugar. I think sugar is the worst thing that patients with cancer or patients without cancer could consume. So I am not a fan of the chocolate chip cookies that you see there. I don't think edible cannabis products are ever medicine because of the sugar. So, as I said, for better control over the onset, the depth, and the duration of the effect, I feel inhalation is optimal. It achieves the higher peak concentration and a shorter duration effect. The slow onset of ingested cannabis may prompt one to overdose. I mean, it's not like an overdose on an opiate. You just feel uncomfortable and you need to get in a dark room and sort of lie down. Again, the topical products probably have less systemic absorption and may have some benefits systemically, but are probably best used locally. So what are the potential side effects of cannabis? Well, again, particularly if people are not used to using it, dizziness is possible, especially if you stand up too quickly. Cannabis can increase the pulse rate and it can increase or decrease the blood pressure. And that's why people who use cannabis and then stand up too quickly may experience dizziness. Dry mouth is common. And again, drowsiness, is that a side effect or a desired effect? I think for people who are looking for help with sleep, it might be a good thing. Euphoria, again, there's that sort of being high. Is that a side effect or is that a desired effect? I guess it's all in the eye of the beholder. I certainly think that people who have a life-threatening disease are entitled to have some euphoria. I think cannabis-induced euphoria, in my opinion, is much healthier than the intoxicating effects of alcohol. The blood pressure changes I mentioned, red eyes, headaches, relaxed muscles. And then there are some people who get paranoid, increased anxious or depression, and that's not good. Impaired memory is something that happens acutely, but people who use cannabis chronically don't have any evidence of impaired learning or other cognitive issues on long-term follow-up tests. We're often asked, well, what is the right dose? And, who knows what product people are talking about? So it's highly individualized. Again, everybody's cannabinoid receptors may be genetically different. So some people smoke cannabis and they always get euphoric, and some people smoke cannabis and get depressed, and some people get paranoid, and some people get no effect. That could be setting, it could be the cannabis that you have, but it also could be the genetics of your cannabinoid receptor. So giving a dose is difficult. What we tell people, and this should be in quotes and have a SIC in parentheses after it because it's not grammatically correct, but it rhymes. So we like to say start low and go slow. So start at the lowest possible dose and increase slowly to achieve the desired effect. Somebody asked the question, 50 milligrams seems like a high dose, while Dr. Rodriguez was talking, and I didn't catch whether that was THC, which would be a high dose, or CBD, which in fact would not be a high dose, because clinical trials of CBD have looked at up to 600 milligrams. That's one thing about CBD. People take from 10 to 600 milligrams. That's quite a wide range. So again, start low and go slowly, but it's the mantra is go slow. And then again, talk to your doctor and see if they can help. Studies have shown that most physicians, although they're in favor of medical cannabis, don't really know enough about it to advise the patient. So what I do is I tell the patients, go to the dispensary, tell the bud tender or the person behind the desk what it is you're trying to treat, and ask them what might work. Another question that we get all the time is, what is the right ratio of CBD to THC that I should take? And again, in animals, CBD seems to reduce the psychotropic effects, or the high, if you will, of THC when the ratio is 8:1 or greater. CBD increases the psychotropic effects of THC when the ratio is 2:1 or less. So that's all in animals, unfortunately, and we don't really know that from humans. And this little 18:1, 8:1, 4:1, 2:1, 1:1 comes from Care by Design, CBD, which is a CBD company. And this is what they postulate are the effects of the different ratios. I tell my patients that the only ratio that's been studied in the medical literature is 1:1. And that is what the drug nabiximols is, which is the drug that 12 patients got in the study that Dr. Rodriguez described, compared to the 9 patients getting placebo. So particularly for my patients with brain tumors who ask me what they should take, I say, well, the medical literature right now supports a 1:1 ratio of CBD to THC. So other safety concerns, again, older people, people with cardiovascular disease, coronary artery disease, should be cautious. I never say avoid, really, but should be cautious about use of cannabis. And both THC and CBD interact with the system in the liver that breaks down prescription medications. Particularly CBD may cause an inhibition of that system so that prescription drugs are going to build up in the bloodstream and could become more toxic. So that's why I'm often concerned about my patients who are taking these very highly concentrated oils of CBD or THC, fearful that it may alter the dose of their prescribed medications, leading to potential toxicity. In our studies of the medical literature, we really found that the only adverse effect in the lungs in people who smoke cannabis is increased cough and sputum, consistent with chronic bronchitis. We, in fact, did not see any evidence of increased lung cancer, perhaps even some suggestion of decreased lung cancer. And again, people who have had bad experiences with cannabis, excessively paranoid or depressed or too anxious, should probably avoid it. And then there's this rare condition that we're learning more and more about as more people use cannabis on a regular basis, hyperemesis, which means too much vomiting. So you get repeated and severe bouts of vomiting. In some patients, it's a rather idiosyncratic reaction, I would say, because we think of cannabis as being an anti-nausea and vomiting medication. But some people, I guess because it's working in the brain on that center, might get it triggered in the wrong direction. And there are medications that people use to treat this, some antipsychotic medications, or many people say taking a warm shower is very helpful. So do not drive if you're under the influence of cannabis is a recommendation that we're going to make. But, you know, I'll tell you what, studies are very unclear about what's happened in states where cannabis has become available recreationally. Whether or not there's an increase in auto accidents is unclear. And I think that people under the influence of cannabis actually are safer drivers than people under the influence of alcohol. When this has been studied in laboratory conditions, people under the influence of cannabis tend to drive more slowly, and they weave a bit more, but they stay within their lane. This is quite different from alcohol. When we looked at the adverse effect on newborns in women who use cannabis during pregnancy, we did not see that many. Babies were born with a slightly lower birth weight, but otherwise there were no long-term damaging effects. But we're going to recommend that if you are pregnant, you might want to avoid cannabis, although many women who have prolonged morning sickness have found it very useful in the 60s and 70s, and I think their children came out pretty normal. So I just want to share a little bit about when you go to a dispensary, you might be overwhelmed by the selection of products that are available. So this is a menu from a dispensary that was online that I took a screenshot of. You can see that the names, people have done studies on these names, and Green Dragon at this dispensary is not going to be necessarily the same plant as Green Dragon at that dispensary. There's indoor and outdoor. Well, why do they tell us the difference between indoor and outdoor? Well, cannabis connoisseurs believe that you can really tell if something is grown outdoors in the sun and wind and rain, or indoors under fluorescent lights and artificial fans and hydroponic water dripping or whatever. So, you know, people feel that maybe indoors sometimes is a little more jangly, as they say. Then they tell you if it's a sativa or indica, and most of what you get in dispensaries are a blend of sativa, indica. It's unusual to get a pure product. Sativa in the folklore is felt to be up and mental, whereas the indica is felt to be more down and physical. So if you're having trouble sleeping, you probably don't want a sativa. If you're having trouble getting motivated, you're not going to want an indica dominant blend. And then this dispensary was just starting to look at CBD content. The third one down has more CBD than THC. The top two are the opposite. And then they give you a little wine spectator one-liner, a bright and cerebral sativa with euphoric overtones. So, you know, we've come a long way in the cannabis world, cannabis business. I find a lot of patients that I see, however, are older, a little confused. They take a lot of different medications, and they don't really want to go to a dispensary. So a few years ago, two PharmDs, two pharmacists graduating from UCSF School of Pharmacy, came to me and said, "What would you think if we opened a dispensary?" And I said, "Well, that would be great." So a year and a half later, they came back and said, "You know what? We found out it cost $1 million down to open a dispensary. So instead, we started a concierge cannabis practice where we'll talk to patients, and for a monthly fee, we'll find out what meds they're taking, what they want to treat, and we'll send them as part of the monthly fee a tincture that we make up for them." So many of my patients have benefited from talking to the folks at Med1 Specialty Care. Their phone number is listed there. In the spirit of full disclosure, they want me to be more involved as a consultant and an advisor, but we have at this point in time no financial relationship. So I do offer this to people that are not cannabis sophisticated, that might want to experiment with some cannabis products, but aren't interested in going to a dispensary and being overwhelmed with all the selections that are available, which certainly when I was growing up in the 60s was not a problem that we worried about. So with that, I'll thank you for your attention, and hopefully we have time to answer some questions.
Thank you so much, Dr. Abrams. That's really wonderful information. Dr. Rodriguez, I'm going to invite you back up. We do have questions that we had in the queue, and please feel free to submit your questions using the Q&A function. We do have about 10 minutes for questions. So here's one of them. I think I'm going to direct this to you, Dr. Abrams. Can you overdose if you consume too much cannabis?
Again, the overdosing usually means, you know, dying and having your respirations turned off. There are very few cannabinoid receptors in the brainstem, which is where our respiratory center is. So in fact, there has never been a report of an overdose, and it's said that you would need to smoke 700 cigarettes in a very short time to overdose, and that would be from carbon monoxide poisoning and not from cannabis poisoning.
Thank you so much. Here's a question that came in. What are your thoughts on RSO? I don't know what that means, but maybe you know.
Yeah, it's named after somebody who's currently on the lam. This is a highly concentrated full cannabis extract oil that is being touted as being a cure for cancer. And as Dr. Rodriguez told us, there is very little evidence in the medical literature that cannabis cures cancer. I think if cannabis is going to have any benefit in any cancer, it's going to be brain tumors because of the high concentration of the cannabinoid receptor in the brain. But this oil, and I'm not going to say the name of the man who is RS because I don't think he deserves that sort of publicity. is something that's sold to patients, and it's what I said I was concerned about, highly concentrated oils being able to interact with people's other medications in a negative fashion so that those medications may become more toxic.
Thank you so much. Dr. Rodriguez, this might be for you or for you as well, Dr. Abrams. Maybe do you know if medical cannabis is covered by insurance?
The answer is no.
No, okay. All right. And for your study as well, Eduardo, there's no coverage as well. They have to get it on their own and purchase it on their own as part of your study.
Yeah, but there's no cost for that. It's just link surveys. So there's no cost to be part of the study. The only caveat that we have is that we prefer people who are being treated at UCSF just because we also are pulling data from their medical records to be a little bit more detailed on what information we get. So if you come from outside of UCSF, you will have to share those with us separately, and that will be another layer, but we can discuss if people are interested.
Thank you so much. Okay, how do I know how many milligrams I'm getting if I'm smoking rather than using a tincture? Is there a measurement? No.
No.
You don't know.
Okay. And what sort of vaporizer would you suggest people buy? Any opinions on that?
Well, I mean, we studied the so-called volcano vaporizer, which is not a portable, all of the studies that we've done have been done in the inpatient setting in the General Clinical Center, Research Center at Zuckerberg, San Francisco General. The volcano is a tabletop centrifuge, it looks like, with a turkey basting bag was the original thing that you use to fill up by a heating element, and a fan fills up this bag. The company that makes the volcano, stores in Bickle, has a number of handheld portable vaporizers. They are, again, much more intricate than a vape pen where you inhale oil. As I mentioned, very concerned about inhaling oil into the lungs as a potential way to damage it. So I would go for a portable vaporizer. Some people enjoy having their own volcano. It's not cheap, but it does deliver a vaporized cannabis, which is probably associated with less harmful particulate matter than actually smoking a cigarette. But a water pipe is also an acceptable way.
Okay, thank you so much. And this is kind of a little bit of dovetailing on that. What is the difference in vaporizing and vaping? Could you explain that again? Because you had mentioned that in your...
Well, I mean, people use them synonymously. But I think vaping has really come to be the term used for those little, things where there's oil in one end and you inhale and it heats the oil and you're inhaling heated oil. That is vaporizing an oil, but that's become synonymous with vaping an oil. Vaporizing is heating to below the point of combustion the plant and inhaling those vapors from the plant that hasn't been heated to the point where it's going to flame up and become ash, but where it's just going to vaporize the active chemicals. So I'm all in favor of vaporization, but vaping has become a nickname for vaporization, and I think it means something else.
Thank you. In any of these studies, how can you account for the possibility that people don't want to mention anything about their use of cannabis? For example, it's stigmatizing for their career. Dr. Rodriguez, do you want to address that first? And then, okay.
Yeah, fortunately, this information that, at least in the United States, all the information that we collect is protected by HIPAA. So we do not disclose it. And even if we share this information with others, like we do in scientific meetings, we do not disclose any information that we call identifiers, meaning dates of birth, workplaces, names, even initials sometimes. We change all those things to be as anonymous as possible. And at least in our study, of course, this is study by study, but in our study, that information that is given to us does not go into the medical record. So it's not subject to be reviewed by insurance or other third parties. It just stays there for research purposes only.
Do you feel that that's the same for other studies as well? They would protect that information?
In our practice, in our clinic, yes. Elsewhere, I can speak for them.
Okay, thank you. All right, is there likely to be much political motivation, either party, Democrats or Republicans, to remove cannabinoids from Schedule I with DEA federal government? If not, how is the cycle ever broken to do more research? Rely on international studies? Anybody want to take that?
It's a very difficult question. Actually, it involves many layers.
Mm-hmm.
From my standpoint, I think it's going to come down, and probably Dr. Abrams can say his own opinion, is going to come down to how much money can people make, unfortunately, rather than how it's impacting actually people's lives. I don't know if there's, I'm pretty sure there should be a partisan division there, but I don't know if one side is more inclined to move forward than the other.
Well, I think we'll just have to wait and see what comes up in the debates, but my namesake, the current, has been the best president we've ever had on cannabis, I have to say. And it's because of what you said, Dr. Rodriguez. He's a businessman, and he appreciates that it's money and taxes. And now pretty much every state has medical cannabis and even recreational cannabis. And his opponent has always been an anti-drug person. So I'm a little concerned.
Okay, thank you. There is a question about sugar use, but I think we might table that because that's a big discussion in and of itself. And maybe we'll do another talk about sugar and cancer. So I'm going to read this question out. This is one that might be difficult to answer because it's quite specific, but Dr. Abrams and Dr. Rodriguez, if you had an oligodendroglioma and it was 40% surgically resected, would you go on a CBD THC regimen to hopefully resolve the remaining tumor? So I'm just going to read a little bit more. I do occasionally take 90-10 ratio of CBD THC gummies in hopes that it will cure me. I have no issues with my traditional cancer treatment side effects. I only take these on hope to eliminate the remaining tumor. So this is about tumor reduction. Any thoughts about that for oligodendroglioma?
Yeah, like we stated before, I think that people need to be treated on a case-by-case basis. These results that we are giving out on research is on a general level. It's not on an individual specific. But like we mentioned, we don't have the medical evidence to say that this will help in humans, at least not right now.
Yeah, I think that's the saddest thing I see in my practice, are patients who are treating a potentially treatable, sorry, my dogs are being fed now. People with a potentially treatable malignancy, maybe not a brain tumor, but who come to me having waited to see me for a number of months, who now have a disease that can't be cured. So I would say, no, you need to treat the remaining tissue the way Dr. Rodriguez and his team would say to treat it, and do not think that CBD or THC in any ratio will work.
Thank you so much. And I think we'll have time for maybe just one quick question if you could stay for one more. Why is THC associated with Prop 65 label, identified by the state of California to be a carcinogen to cause reproductive harm? Anybody want to take that one?
I think they have to say that about pretty much anything that they don't know enough about.
Okay. Well, I think that's all the time we have for questions from Dr. Abrams and Dr. Rodriguez. I want to thank you both so much for your time, your expertise. We really, really appreciate it. And thank you again for being here. And thank you to all of you for joining us for this presentation. It's wonderful to have you here. We wish you well and hope to see you again in a future webinar.